Have you ever found yourself just staring at a medical bill? Or maybe that explanation of benefits, the EOB, and felt like you needed, I don't know, a secret decoder ring just to figure out what's going on.
Oh, absolutely.
You see a charge, then you see what the insurance paid, and then there's this adjustment. It's often totally cryptic, right?
Yeah.
And it leaves you with way more questions than answers.
It really does. That feeling of confusion. It's incredibly common because these documents, well, they're critical financially and legally, but they're just packed with specialized information.
Right.
And without the right key, like you said, it's like trying to read a complex financial report that's, written in code, numbers, acronyms flying at you, no clear story.
Exactly. And that's precisely what we're going to unravel today here on the Deep Dive.
Yeah.
Our mission is to crack that code. We want to give you the insider knowledge on two absolutely essential sets of codes that explain why your insurance company paid what it did, or maybe denied a claim or adjusted a payment. We're talking about CARCs and RARC codes. And understanding these, it isn't just for, the healthcare pros buried in billing. It's really a shortcut to being truly well-informed about medical billing for anyone who's curious about how these complex systems work, or even if you're just navigating your own healthcare journey and want to feel a bit more empowered.
And this deep dive, it's built on a pretty comprehensive set of sources. We've got some really fascinating excerpts from a source called Mastering Medical Claim Adjustment Codes, CARC and RRC.
Ah, okay.
It's genuinely a foundational text for, demystifying this often really opaque part of the whole healthcare ecosystem. It helps turn what feel like arbitrary decisions into something clear, something understandable, logical.
So it's kind of like we're getting a diagnostic readout for your medical bills. You know how your car's dashboard lights up?
Yeah.
But unless you know what that little symbol means, you're just left scratching your head, right? Well, navigating a medical claim without these codes feels just like that. You know something happened, but you're totally in the dark about why, or, crucially, what you're supposed to do next.
That's a perfect analogy.
So let's unpack this. Let's start with the absolute basics. What are CARC and RRCC codes, at their most fundamental level? Because I think for most of us, these acronyms probably mean very little until now.
Okay, so at their core, CIRC and RRRC codes are standardized codes. Think of them like a universal language, one that's adopted across the entire healthcare industry. It ensures everyone from like a tiny clinic to a massive insurance company can communicate payment decisions clearly and consistently.
Got it.
You'll mostly see them in two key documents. The Electronic Remittance Advice, or ERA, that's the detailed payment summary providers get from insurers.
Right, the provider side.
Exactly. And then the Explanation of Benefits, or EOB, which is the document patients like you receive.
The one we all get in the mail or online.
That's the one. And their primary, really vital purpose is to indicate why a medical claim was paid differently than it was originally submitted, or why it might have been denied completely, or why it was adjusted by the insurance payer.
So if you're a patient, this is that often confusing paper or maybe digital document you get after a doctor's visit or a procedure. It details what your insurance covered, what they didn't, and supposedly why. And for providers, the ERA, that's their essential report from the insurer, breaking down the financial outcome for every single claim they've sent out, often for, I imagine, hundreds or thousands of patients at once.
Precisely. These documents are really the ultimate financial summaries for a medical claim. And without these codes embedded in them, understanding the exact financial outcome would be, nearly impossible.
Right.
Just imagine getting a bill that just says adjusted or denied with zero explanation.
Chaos.
Yeah, that's basically the chaos these codes prevent. They bring this really crucial layer of transparency to what can otherwise be a very opaque, honestly, frustrating process for everyone involved.
Okay, that makes sense. And even at this initial stage, you mentioned there are two different types, CR and RRC. And you give us that sort of initial distinction just to set the stage for the deeper dive. What's the main difference we should keep in mind?
Sure. So the Claim Adjustment Reason Code, CRRC, that's focused on the reason for an adjustment.
Okay.
And it tells you what happened. So if a payment was reduced or denied, the RRC gives you that primary sort of overarching explanation.
Gotcha.
Then you have the Remittance Advice Remark Code, or RRRs, and that provides additional information about the adjustment.
Ah, okay. More detail.
Exactly. It dives deeper. It might give you the why behind the DARC, or even, really importantly, the what next, like guiding you on how to resolve the issue. They work together hand in hand, but they each have a distinct role.
What and why? Or what next?
You got it. And what's truly fascinating here, I think, is how these seemingly small codes really form the backbone of communication between payers and providers. They standardize these highly complex financial transactions. They make sense of why a claim might not be paid in full or why it might be denied outright. Before these codes, every insurance company might have had their own unique proprietary way of explaining a denial.
Oh, what a nightmare.
Imagine immense confusion, huge administrative burden for providers who had to learn like dozens of different languages.
Right.
So this standardization, it's a quiet but really powerful force for efficiency in a very complex system. It allows for much smoother interactions.
It's the framework that makes consistent processing even possible. Okay, so let's peel back the layers. Let's start with the what? Diving deep into claim adjustment reason codes, the CARCs. What's their precise purpose, and what should we be looking for?
Okay, so the precise purpose of CARCs is to identify the primary reason why a claim, or sometimes just a part of a claim, wasn't paid in full, or why it was denied completely or maybe reduced from the original amount charged.
The main reason, the headline.
Exactly. Think of it as the headline reason for the claim's financial status. It's the first, most important piece of information you need to understand that initial decision. Without this, you're flying blind.
And what are the defining features of these CR codes? Like, how do you spot them visually on an EOB or an ERA?
They have very specific characteristics. First, they are always assigned by the payer.
Okay, the insurance company decides.
Right, the insurance company puts the code on. Also, they are consistently numeric.
Just numbers.
Just numbers. So you'll see codes like 1, 2, 29, or 45. That numeric format makes them pretty easy to identify.
Okay.
Now, importantly for healthcare providers, CARCs are heavily used in their internal reporting and for managing denials. They track these codes. They're a critical metric for a practice's financial health.
Makes sense.
And maybe most crucially, they are required for processing appeals and resubmissions.
That's key.
Absolutely.
But
if a claim is denied, you absolutely need that CARC code to even begin the process of challenging the decision or resubmitting the claim correctly. It's your starting point for any kind of follow-up action.
That's a huge point about appeals. You can't just send a letter saying, hey, you didn't pay.
Right.
You need to know why they didn't pay to even start trying to get it covered.
Yeah.
Okay, let's walk through some specific examples from our source material. This is where the theory really clicks into, real-world understanding for our listener. What does CRC1 mean?
CRC1 is super common. It means deductible amount.
The deductible. Okay.
Yeah, this just confirms that a portion or maybe even all of the claimed amount was applied to that familiar initial out-of-pocket hurdle you need to clear before your insurance really starts covering services.
Right. The amount you have to pay first each year.
Exactly. It's the system's way of saying, look, this is your agreed-upon share for now, as per your policy. So if you see CRC1 on your EOB, it's not really a denial in the sense that the service wasn't covered. It's more an explanation that you're still responsible for that amount because you haven't hit your policy's deductible yet.
Right.
And for providers, this means they need to collect that portion directly from the patient.
That makes perfect sense for patients. We see that one a lot. What about CR2?
CR2 is similar, but it refers to the coinsurance amount.
Coinsurance. Okay. The percentage part.
Exactly. After your deductible is met, many plans require you to pay a percentage of the allowed cost for a service that's your coinsurance.
Like 20% or something.
Right. For instance, if a service costs, say, $100 and your coinsurance is 20%, after you've met your deductible, you typically pay $20 and the insurer would pay $80. CR2 just indicates that the adjustment reflects this percentage-based patient responsibility.
Okay.
So for both CRC1 and 2, these are pretty standard patient responsibilities. The code just tells you why the insurer isn't paying 100% of the bill.
Got it. Those first two make a lot of sense for patients. Now, what about CRC 29? The time limit for filing has expired. Oof. It sounds like a big deal, especially in the fast-paced world of healthcare.
It is a very big deal, and it can be a critical financial blow, especially for providers.
I bet.
Medical insurance claims have strict, non-negotiable deadlines for submission. Often it's like 90 to 180 days from the date of service.
Okay.
If a claim is submitted even one day after that deadline, the payer will deny it. And CR29 is the flag for that denial.
Wow.
Imagine a small clinic discovering maybe a batch of claims went out a week late because of a software glitch or maybe a staffing shortage.
Oh, no.
Every single one of those claims would come back with CARC29.
Yeah.
That could potentially wipe out a substantial chunk of their monthly revenue because these services often just become write-offs.
They can't get paid for them at all.
Often no. And for patients, this code is actually a rare instance where a provider's error might protect you.
Wow.
Well, in many states, if a claim is denied specifically for timely filing, the provider actually forfeits their right to bill the patient for that service.
Get out. Seriously.
Seriously. So, seeing CR29 on your EOB might mean you're off the hook financially. But, and this is important, you need to understand your state's specific regulations because some providers might still try to balance bill you.
Okay, good to know. But it definitely signals a major administrative mess up on the provider's side.
Absolutely. A breakdown in their process.
Wow. Okay, so that's not just a minor oversight. It's a massive financial risk for providers.
Yeah.
Okay, what about CR45? Charge exceeds fee schedule maximum allowable.
Ah, yes. This code really highlights that intricate dance of negotiated rates in healthcare.
Right, the secret prices.
Kind of. Many patients might not realize this happens. Fee schedules and maximum allowable payments are basically pre-negotiated rates between an insurer and a healthcare provider for specific services.
Like a contract.
Exactly like a contract. The insurer agrees to pay up to a certain amount for a procedure, and the provider, if they're in-network, agrees to accept that amount as payment in full, apart from patient responsibility like deductibles or coinsurance.
Okay.
So if a provider charges, say, $150 for a service, but their contracted rate, the maximum allowable, is only $100.
Then CR45 pops up.
Precisely. CR45 indicates that the payer has reduced the payment down to that pre-negotiated $100 rate. And the difference, that extra $50, that's typically a write-off for the provider. They cannot bill an in-network patient for that excess amount.
Okay, so if my doctor tries to bill $100, but their contract with my insurer says that procedure is only worth $70, the insurer pays up to $70, and CR45 explains why the other $30 wasn't paid. And for me, the patient, that $30 is usually not my problem if I stayed in network. That's powerful to know.
It is. It clarifies the adjustment is purely due to the contracted rate, and it protects the patient from being billed for charges above that agreed-upon amount. Huge protection.
Good. Okay, and CR96.
Yeah.
Non-covered charges.
This is another very common one for patients, and yeah, often a source of frustration.
That's amazing.
CRX96 means that the service that was billed is simply not included in the patient's specific insurance plan.
Not covered, period.
Right. You might have experienced this if your doctor recommended a service, maybe a specific type of therapy or an experimental treatment or certain elective procedures, but your particular policy just doesn't cover it.
Yeah.
This code tells you definitively, this service is not a covered benefit under your insurance contract. And unlike deductibles or coinsurance, where the service is covered but you owe a portion.
Right.
With CARC96, the insurer pays nothing. Zero. And the patient is typically responsible for the full cost of that service. It's a direct signal that the service falls outside your policy scope.
Okay, clear, if not always welcome news. And finally, for cease, let's look at Code 109. Claim not covered by this payer contractor. This one sounds like it can mean a few different things.
It can, yes. This usually indicates that the claim was submitted to the wrong insurance company entirely.
Ah, like sending it to Blue Cross when the patient has Aetna.
Exactly. Or maybe the patient has multiple policies, perhaps one for medical and a separate one for vision or dental. Or maybe they switched plans recently and the claim went to the old insurer by mistake.
Okay.
This code is basically a sign that says, whoa, wrong address. The claim needs to be resubmitted to the correct payer. Or it could mean the patient's coverage for that specific type of service is actually handled by a different entity, maybe a carve-out for mental health or pharmacy benefits through a different plan.
So for a billing team, this means research time. Got to find the right coverage.
Correct. They need to dig into the patient's current active coverage details.
It's really fascinating how much narrative is packed into these seemingly dry codes, isn't it?
It really is.
They're not just random numbers. They're literally telling you the story of your claim. They're providing a very specific reason for why that payment came back the way it did.
And if we connect this to the bigger picture, CARCs are like the initial flag bearers. They quickly communicate the primary issue. That's essential for providers trying to triage all their outstanding claims and understand the immediate financial impact.
Right.
Without these concise, standardized reasons, the sheer volume of unpaid or partially paid claims would just be unmanageable. They allow for rapid classification and prioritization of claim outcomes, turning what could be a mountain of outstanding debt into organized, actionable categories.
Absolutely. Okay, so we've talked about the what with CARCs. Now let's pivot to the why, or maybe the what next. Let's unpack Remittance Advice Remark Codes, or RARCs. What's their purpose, and how do they add to the picture that CARC started?
Right, so while CARCs give you that headline reason, RARCs provide that crucial extra context or explanation for a denial or a payment adjustment.
The backstory.
Kind of. They're incredibly helpful for billing staff and providers because they often clarify the why behind the CARC, and really importantly, they often suggest what to do next.
Ah, actionable intelligence.
Exactly. They fill in the informational gaps and provide these actionable insights, often hinting at the specific administrative or documentation issues that led to the adjustment in the first place.
Okay, and what are their key characteristics? How do they differ from CARCs? How do we spot them?
Well, the most obvious characteristic and a key differentiator from CARCs is that they are alphanumeric.
Letters and numbers.
Right. You'll see codes like N29 or M15, often starting with a letter like M for medical or N for note. This format makes them visually distinct from the purely numeric CARCs.
Okay, that's a good tip.
Secondly, they are not always present. A claim might have a CARC explaining the adjustment without any accompanying RARC.
They're optional.
Technically, yes, but when an RARC is present, it's highly useful. Think of it almost like an internal memo from the insurer system to the provider's billing team.
Gotcha.
They typically provide specific clarification or suggest next steps, like indicating a need for additional medical records or clarifying a specific policy nuance.
So for a billing specialist, an RRC is basically like a direct instruction from the insurance company, cutting out the guesswork. Like, hey, we denied this for X reason, but here's the exact thing you need to do to fix it.
That's a great way to put it. It's an invaluable shortcut. Imagine the alternative. You get a vague denial, and your team spends hours on the phone digging through policy manuals, trying to reverse engineer the problem.
Huh.
RRCs streamline that entire follow-up process. They can turn frustration into a clear action item. Let's look at some examples from our sources. What does RRC M15 signify?
Okay, M15.
RRC M15 means separately billed services have been bundled. This refers to a really common practice in medical billing called bundling.
Bundling, okay.
If you see M15, it means the insurer looked at several distinct services listed on the claim, but their policy, or maybe industry standards, considers them all part of one larger single procedure. Therefore, they're paid as one combined charge, not separately.
Can you give an example?
Sure. Let's say a surgeon bills separately for the surgery itself, then also for the anesthesia administration during the surgery, and maybe for a specific post-operative follow-up visit done on the same day.
Okay.
The insurer might come back with RRCM15 and say, wait a minute, anesthesia and routine post-op care are typically bundled into the main surgical code payment. We don't pay for those separately. It simplifies billing for related procedures and prevents, overbilling for every little component of a single service.
Got it. It's about paying comprehensively for the whole episode, not piece by piece necessarily. Okay, what about RRC N29? Missing documentation or records.
N29. This code points to a critical administrative hurdle that often causes delays or denial.
Paperwork issues.
Exactly. It means the insurance company needs more information to process the claim specifically. Some required documentation or medical records that weren't included or maybe were incomplete with the initial claim submission.
Like what kind of records?
Could be anything, really. Operative notes for a surgery, lab results to justify a test, maybe a referral from a primary care physician that was required but wasn't sent in.
Okay.
Now, the good news is this is often a straightforward fix for providers.
Just send the missing stuff.
Pretty much. Yeah. Just send the requested records, and the claim can often be reprocessed fairly quickly. It's a clear signal for administrative follow-up that, if addressed promptly, can turn that denial right back into a payment.
Good. A clear action item for the billing team. Okay, how about RRC N56? Procedure code not valid for this date of service.
Ooh, this one's about compliance and timing, and yeah, it can be tricky.
How so?
Well, medical procedures sometimes have very specific rules about when they can be performed or under what circumstances they can be billed, or maybe even where they have to be performed.
Okay.
For instance, a particular procedure might only be covered if it's performed in a hospital setting for a specific diagnosis, not in an office. Or maybe it requires a certain diagnostic test to be done first, and that wasn't documented or billed.
I see.
N56 indicates that the procedure code used on the claim doesn't align with these rules, or maybe the patient's documented clinical situation for the specific date it was rendered. It points to a timing or compliance issue that needs review. Maybe it needs a medical necessity appeal with more documentation, or maybe even a correction if the wrong procedure code was used accidentally.
Lots of possibilities there. Okay, then there's MA18, claim adjustment because of late filing. Didn't we cover late filing with a CEEC?
We did, with CARC 29, that's the primary reason code. MA18 often appears alongside CARC 29.
As extra confirmation.
Exactly. It might offer further nuance or simply serve as an additional confirmation from the payer system that late filing was indeed the precise reason for the adjustment or denial. It's like underlining the point.
Okay.
Sometimes it might provide a slightly more detailed internal note about why the late filing denial was triggered in their specific system. But essentially, it functions as an extra layer of clarity, leaving absolutely no doubt about the cause of the denial.
Got it. Double-checking the reason. And finally, RRC N3A2. Missing in a complete and valid patient identifier.
This is a classic administrative error, but boy, does it highlight the absolute importance of accurate patient information.
Like a typo.
Could be a simple typo, a transposed number in a patient ID, a missing date of birth, an incorrect insurance subscriber ID. Any of these can cause a huge headache.
I bet.
It can lead to claims being held up, denied, or even paid incorrectly. M382 points directly to that administrative data issue. It's a very specific instruction for the billing team. Go back, verify the patient's identification details with extreme care.
Yeah.
It's a reminder that even small data entry errors can have pretty big financial consequences down the line.
Definitely. This raises an important question, though. Without RRCs, billing teams would be doing what? Just playing a frustrating guessing game, trying to deduce why a claim got kicked back.
Absolutely. A total guessing game. RARCs are those critical instructional notes. They allow for targeted follow-up and much faster resolution. They transform a vague denial into a clear action item, preventing countless hours of, manual investigation, phone calls back and forth.
Wasted time and effort.
Totally. It's efficiency personified, really, in just a few alphanumeric characters.
So if CARC tells you the headline news, RARC swoops in with the critical fine print, the oat. And by the way, here's how you fix its details. It's really the narrative that guides your next move.
Yeah.
I can only imagine the sheer chaos before these existed. Just pure guesswork for billing teams, right?
Oh, it would be an absolute nightmare, no question. CARCs were revolutionary because they transformed that vague no into a clear do this, saving, like we said, countless hours. This combined information is just invaluable.
Right.
Instead of just knowing a claim was denied, you know why and precisely where to look for resolution, it transforms a simple denial into an actionable item for the billing department. It's the difference between knowing the car won't start, that's the CARC, and knowing the car won't start because the battery is dead, and here's the specific voltage reading that confirms it. That's the RRC adding the crucial detail.
That's where the aha moment really kicks in, isn't it? It's not just a reason, it's potentially a path forward. Knowing these codes together is where the real power lies. Okay, let's dig into how CARC and RRs truly work together as a dynamic duo.
Okay. Well, the best way to think about their relationship is probably through that analogy from our source material. RRs tells you what happened to the claim.
What happened?
For example, maybe it was denied for no authorization. That's the what.
Okay.
Then RRC tells you why it happened or what to do next. For example, maybe the RRC says, authorization number not submitted, please attach proof of referral.
Ah, okay. The what and the why or how to fix it.
Exactly. They're distinct, but they're perfectly complementary pieces of information. One gives the primary reason, the other gives the deeper context or the solution. Together, they form a complete picture of the claim status and what needs to happen next.
Can you give us a concrete example, like a real-world scenario from an ERA, just to illustrate their combined power and show how they paint that full picture?
Yeah, absolutely. Our source provides a really clear scenario that illustrates this perfectly. Imagine a claim is submitted and then it gets denied.
Okay.
On the electronic remittance advice, the ERA, the provider receives, they might see, a CARC, 27 expenses incurred after coverage terminated.
Okay, CRRC 27, coverage ended.
Right. This tells the billing team immediately, unequivocally, that the claim was denied because the patient was no longer covered by that insurance plan when the service was actually rendered. That's the primary reason for the denial. It's definitive.
Got it. Core reason right there.
Yeah.
But what about the RRC that might accompany it? What additional insight could that provide?
Okay, so alongside that CR27, you might see something like RRC, N130, consult plan benefit documents for more information.
N130,
Yeah.
consult plan documents.
Exactly. So here, CRC27 gives the specific primary denial reason patient wasn't covered. But RRC N130 provides the crucial next step or maybe some additional context.
Right.
It prompts the provider, or even the patient if they're looking closely at their EOB, to go and review the specifics of the insurance plan documents. Confirm coverage dates, limitations, effective dates, termination dates.
Okay.
It directs the user to the precise information needed for potential follow-up or clarification. Maybe to verify if a different insurance policy was actually active, or to confirm that a previous policy had indeed ended before the service date. It's an actionable clue, tells you where to look next.
So it's like the CRC gives you the bad news coverage terminated, and the RC gives you the manual, or at least tells you where to find the manual.
Yeah.
Check the plan documents on how to deal with that bad news, or at least where to find the specific answers.
That's a great way to frame it.
That truly highlights why knowing both is so important for getting things resolved quickly. Okay, now let's take a step back and look at them side by side. Our source provides a fantastic differences at a glance table. Let's walk through that just to really solidify their distinctions and maybe their shared ground for our listener.
Yeah.
First up, their full forms again.
Right. So CARC stands for Claim Adjustment Reason Code. Pretty clearly states its purpose, the primary reason for an adjustment.
Reason code.
And RAC stands for Remittance Advice Remark Code. Again, indicating its role providing remarks or additional clarifying information on the remittance advice, the payment summary.
Remark code. Oh.
The names themselves are actually quite descriptive once you understand their function.
Yeah, they make sense now. And the format, that's a key differentiator, isn't it? An easy visual cue.
Absolutely. CARCs are always numeric, simple codes like 1, 45, 96, just numbers.
Numbers only.
RARCs, on the other hand, are alphanumeric. They combine letters and numbers like N130 or M15. That's often the quickest visual clue to tell them apart when you're scanning an ERA or an EOB.
Numeric versus alphanumeric.
Got it.
What about their core purpose? Just summarize briefly again.
Okay, core purpose. RARC explains why a claim or payment was adjusted. It's the specific cause of the financial outcome.
A why.
RRC, in contrast, adds extra context or instruction. It delves deeper into the how or what next related to that adjustment.
More detailed. Next steps.
Right. Think of RARC as the reason for the decision and RRC as the further explanation or action required.
Okay. Now, is one more important or more consistently present than the other? Is there like a hierarchy?
Yes, there is. CARCs are required in the electronic remittance advice. Mandatory.
Always there if there's an adjustment.
Exactly. You will always find a CARC explaining any adjustment or denial. They are mandatory for clear financial communication. RRCs, on the other hand, while highly recommended and incredibly useful for efficiency, they are technically optional.
Optional but recommended.
Right. Their absence doesn't mean there's no explanation. You still have the CR. But their presence provides invaluable clarity and often really streamlines the follow-up process. So it indicates that the core reason is always provided, while the extra detail is often there, but not guaranteed, to help accelerate resolution.
Makes sense. And who are the primary users of these codes? Is it mainly the billing departments, or do others leverage them too?
Well, both are used broadly. Healthcare providers, medical coders, billing staff, and they're deeply integrated into sophisticated billing software. Everyone in that chain uses them.
Okay.
However, RRCs are often cited as being especially useful for the follow-up process, given their instructional nature.
Right, the what next?
Exactly. They directly guide the specific actions needed for reprocessing claims, filing appeals, or correcting underlying issues. They are essentially the workflow catalysts, you could say, for billing departments.
Workflow catalysts, I like that.
Okay.
We've gone through a bunch of examples already, but just to reiterate, maybe a couple of distinct ones for each again.
Sure. For CARCs, we saw Code 1 indicating a deductible amount and Code 96 for a non-covered charge. Those are straightforward primary reasons.
Yep.
For RXCs, we discussed N56, pointing to a procedure code not valid for the date of service, maybe a timing issue, and MA18, confirming a late filing adjustment. These really illustrate how RKs add that extra nuance or direct instruction.
Okay. And crucially, who manages these code sets? Because standardization like this doesn't just happen by magic in such a vast and complex system like U.S. healthcare.
No, it definitely doesn't. And this is a critical point that really underpins the entire system's functionality. Both TR and RB codes are managed by X12 and CMS.
X12 and CMS. Okay, who are they?
So X12 is an organization responsible for developing and maintaining electronic data interchange, or EDI, standards for the healthcare industry, among others. They essentially create the grammar for how different entities like providers and payers communicate electronically.
The technical rules.
Right. And CMS, the Centers for Medicare and Medicaid Services, as the largest single payer in the U.S. and a major regulatory body, plays a huge role in defining and adopting these standards.
Okay.
And what's truly fascinating here, and really important, is that while CARCs and RARCs serve distinct purposes, their shared management by these authoritative bodies ensures a unified, standardized system across virtually all payers, commercial insurers, government plans like Medicare and Medicaid, everyone.
Wow. So everyone uses the same codes?
Largely, yes.
Yeah.
This standardization is absolutely critical for consistency and efficiency in a very, very complex revenue cycle. It allows all these different entities to speak the same language when they're exchanging sensitive financial information. It greatly reduces administrative friction and confusion.
So while they are different, CARC and RARC, they're both speaking the same languages, maybe with different accents, if you will, to help you get the full picture.
That's a good way to put it.
And that shared oversight by X12 and CMS really underpins the whole system, preventing what sounds like it could have been utter chaos otherwise.
Exactly. It's the framework that makes such a complex system function, at least in this regard. Without that overarching management and standardization, yeah, every payer could just invent their own codes and formats. Imagine the administrative burden for providers who often deal with hundreds of different payers, each with potentially different rules.
A nightmare. An impossible nightmare.
Precisely. It would be a nightmare of incompatible systems.
Okay. Now that we understand what they are and how they work together, let's explore their vital, really strategic role in something called revenue cycle management, or RCM. For those listening who might be unfamiliar, what exactly is revenue cycle management in a healthcare context?
Okay, so revenue cycle management, RCM, it encompasses the entire financial and administrative process in healthcare. It starts from the very moment a patient registers for a service,
The beginning.
all the way through to the final payment collection. It's truly the lifeblood of any healthcare provider, financially speaking. It includes everything from patient scheduling, verifying insurance eligibility, accurately coding diagnoses and procedures, using other code sets like ICD and CPT,
Yeah, the medical codes.
then submitting the claims, managing any denials that come back, which is where CARCs and ARCs are huge, handling appeals, and ultimately posting the payments received and reconciling the accounts.
The whole financial journey of a patient encounter.
Exactly. And these codes, CARC and RARC, they aren't just important for understanding individual claims. They are absolutely integral to the overall efficiency, accuracy, and crucially, the financial health of this entire cycle. Without them functioning properly, the revenue cycle would just grind to a halt.
So it's essentially the financial engine of a healthcare practice or a hospital, ensuring they actually get paid for the services they provide.
Okay, how are CR and RCM codes actively used within these RCM processes? Let's start with denial management, which sounds like it must be a constant battle. Oh, it is. And for denial management, providers heavily rely on CR codes specifically to identify trends in denials. This is where the strategic insights really come in.
Trends, okay, like patterns.
Exactly. Imagine a large hospital system suddenly noticing a significant spike in CR 45 denials that's charge exceeds fee schedule for a specific type of surgical procedure. And maybe it's happening particularly with one major insurance payer.
Okay.
That's a huge flashing red flag for that provider. It tells them they need to immediately review their pricing strategy for that procedure or maybe try to renegotiate their contract terms with that specific insurer.
So it's not just fixing one claim, it's seeing a bigger problem.
Precisely. It allows them to move beyond fixing individual claim issues to identifying and addressing systemic problems that could be costing them potentially millions of dollars. They can pinpoint exactly where their revenue is getting stuck and why.
That's a powerful insight. It helps them spot those recurring issues rather than treating each denial as a one-off, which sounds like an endless game of whack-a-mole.
It would be, yeah.
What about appeals? This seems like another critical area where these codes would be essential.
Absolutely essential for appeals. You could say CIRC and RRC codes are the ammunition for appeals.
Okay.
They are used in combination to craft effective, targeted appeal letters. You simply cannot appeal effectively if you don't know the exact reason for the denial and any additional context or instruction needed for resolution.
Right, you need the specifics.
Exactly. The CRR provides the primary reason for denial. The RARC often provides the why, maybe the specific piece of missing documentation that was needed, or clarification about how a policy was applied. This specificity is critical for formulating a successful appeal. It ensures the provider addresses the precise issue the payer identified, rather than just sending a generic plea like, please reconsider.
Yeah, that probably doesn't work too well.
Not usually, no. Without these codes guiding the appeal, it would literally be a shot in the dark, a wasteful and often futile exercise.
It sounds like they're providing the detailed blueprint for the appeal, making it so much more likely to actually succeed. Okay, what about reporting and analytics? How are they used there?
In reporting, these codes allow healthcare organizations to generate key performance indicators, or KPIs, by denial type.
KPIs, okay. Metrics.
Right. For instance, a billing manager can track, say, the number of CARC 96 denials, those non-covered charges, in a given month. Or they can see how many claims are being denied with CARC 29 because of timely filing issues.
Ah, tracking problem areas.
Exactly. This data is vital for measuring their billing performance, identifying areas of weakness in their internal processes, and understanding the financial implications of different types of denials. It helps management assess the efficiency and effectiveness of their entire billing operation, pinpointing exactly where they might be losing revenue or encountering bottlenecks in their workflow.
And finally, process improvement. How do these codes help healthcare organizations proactively get better at what they do, beyond just reacting?
This is where the real long-term strategic value comes in, moving beyond just fixing individual claims. By identifying recurring issues through consistent CAR and RARC analysis.
The trend analysis again.
Right. Healthcare organizations can proactively find and fix the underlying root causes of problems. For example, if they frequently see that RARC 45 charge exceeds fee schedule for a particular service with a particular payer, it prompts them to maybe adjust their pricing strategy for that service, update their internal charge master list, or even, as we said, try to renegotiate their contract with that specific payer to better align with the allowable rates.
Fixing it upstream.
Exactly. Or similarly, if they see a high volume of RC N29s for missing documentation related to, say, surgical procedures, that might lead them to implement new internal checklists for the social teams, or maybe even automated prompts in their electronic health record system to ensure all required operative notes and reports are attached before a claim even gets submitted.
Preventing the problem in the first place.
Precisely. This moves beyond just reacting to denials. It's about optimizing the entire billing process from start to finish. And the goal is fewer denials overall, improved compliance, and a much healthier, more predictable revenue stream.
Yeah.
And like we keep saying, this isn't just about getting one claim paid. It's about optimizing the entire financial health and sustainability of a healthcare practice, which ultimately ensures they can continue delivering care to patients.
So what does this all mean for the big picture then? These codes, CARC and RRC, they aren't just for explanation after the fact. They're really powerful, granular tools for improving the entire financial health of healthcare providers. They lead to a much smoother, more predictable operation by making the invisible problems visible.
Absolutely. This demonstrates how truly vital these codes are beyond just settling a single claim. They are foundational to the strategic financial health of any medical practice, large or small. Effective revenue cycle management, which is driven by the intelligent analysis and use of CARC and RRC data, directly impacts a provider's ability to remain financially viable and continue delivering essential care to their communities. It's really the difference between merely reacting to problems as they pop up and proactively preventing them, building a much more robust financial future for the practice.
We've covered a lot of ground today.
Yeah.
From deciphering specific numeric and alphanumeric codes to really understanding their profound strategic role in the massive machinery of healthcare finance. So let's bring it all home. Why do these codes truly matter to you, our listener? Whether you're a patient just trying to understand your bills, a curious observer, or even a professional looking for that deeper understanding.
Well, the core conclusion from our sources is really clear. Both TR and RRC codes are absolutely essential for understanding payment decisions from insurance payers, period. While CARC gives you that primary denial reason, the what RRC offers that crucial clarification, or the next steps, the why, or what to do next. Mastering them, or at least understanding their basic function, means understanding your medical bills in a way most people simply don't. Whether you're a patient trying to make sense of your own EOB or a professional seeking to optimize operations.
And the tangible outcomes of effectively using these codes are pretty significant, right?
Yeah.
Both for providers and, as you said, indirectly for patients. What are those direct benefits that kind of ripple through the system?
Okay, so for providers, the benefits are huge. First, significantly faster denial resolution.
Less chasing money.
Exactly. Less time spent chasing payments or dealing with administrative headaches means their resources, both financial and human, can be better allocated to actual patient care.
Right.
This leads directly to improved cash flow for the practice. Payments come in more reliably and quickly, which is critical for operating any healthcare business.
Makes sense.
Another key metric they track is reduced AR days. AR stands for accounts receivable days.
Okay, what's that?
It's basically the average time it takes for a service to be paid for after it's been provided. Reducing AR days is a clear, undeniable sign of financial efficiency and health for a medical practice. Lower is better.
Got it. Less time waiting for money.
Exactly. And finally, these codes lead to much better claim reprocessing. When a claim does need to be resubmitted, maybe after fixing an error identified by RC,
Yeah.
the correct codes guide a more accurate and efficient reprocessing, drastically increasing the likelihood of timely payment on the second attempt. Less rework, better results.
So these are huge wins for providers. But how do these benefits for providers circle back and indirectly benefit us, the patient, the listener navigating their own healthcare journey?
That's a great question. When providers have faster, more efficient billing processes driven by this code-based clarity, it creates a powerful positive ripple effect that benefits you, the patient.
How so?
Well, for one, you are more likely to receive clearer, less confusing EOBs because the payer and provider are actually communicating more effectively about why adjustments were made.
Okay, less confusing paperwork. That's a win.
Definitely. This can lead to significantly fewer unexpected or incorrect bills landing in your mailbox. That means less stress, less confusion, and fewer of those frustrating phone calls trying to sort things out.
Yeah, nobody likes those calls.
Nobody. And think about it. If a provider is efficient at getting paid correctly the first time, they spend less time and fewer resources on administrative tasks.
And more time on care.
Potentially, yes, or at least the whole system runs more smoothly. Ultimately, a smoother overall experience with the complex healthcare system is the likely outcome for you. When the financial engine runs well behind the scenes, the patient experience up front is often significantly improved. Less administrative burden for providers often translates eventually to less administrative burden and confusion for you.
So whether you're a provider trying to streamline your operations or just a patient trying to make sense of that latest EOB that landed in your mailbox, understanding these codes truly gives you a leg up. It really is like having a secret decoder ring for your medical bills.
It really is.
Knowing what those numeric and alphanumeric strings actually mean can transform that feeling of frustration into understanding and confusion into clarity. It feels like true empowerment.
And knowledge is most valuable when it's understood and then applied. By grasping these codes, even at a basic level, you empower yourself. You can ask more informed questions. You can challenge incorrect billing with specific, undeniable evidence based on the codes you see. And ultimately, you can navigate the complex world of healthcare finance with much greater confidence.
Yeah.
It shifts the dynamic from feeling, overwhelmed and maybe helpless to feeling more in control and well-informed. It's about turning a source of anxiety into an area where you feel you have some competence.
We've taken quite a deep dive today, haven't we? Into the hitter language of medical claim adjustments. From the specific reasons provided by those numeric CARC codes to the crucial additional context and those all-important next steps offered by the alphanumeric RARC codes. We've seen how they combine forces to explain complex payment decisions and how they are absolutely vital for the efficient functioning of healthcare's entire revenue cycle, really underpinning its financial health.
They really represent a standardized, systematic approach to bringing clarity to these millions upon millions of financial transactions that affect almost everyone every single day. It's kind of a testament to how complex, often frustrating systems can be made more comprehensible through structured, universal communication tools like these codes. They are truly the unsung heroes of medical billing, in a way.
Unsung heroes, I like that. So final thought then, given the incredible precision and detail embedded in these codes, how they manage to transform potential chaos into clarity in healthcare finance. It makes you wonder, doesn't it? What other seemingly opaque systems in our daily lives might also have a kind of hidden language, just waiting for us to decipher it for greater efficiency, better understanding, and maybe even more personal empowerment.
That's a fascinating thought to end on.
It makes you wonder, right? And maybe the next time you get an EOB, you might just find yourself actually looking for those numeric CRE codes and those alphanumeric RRC clues, knowing that now you're a little more fluent in the secret language of claim adjustments. You've got the decoder ring.